Welcome to Pharmacy to Dose, the Critical Care Podcast, where we're discussing critical care and its pharmacotherapy in a fun and entertaining manner. And I'm your host, Nick Peters. Wherever you are and however you are listening, thank you. And a quick word from our sponsor, QXMD. QXMD builds mobile solutions that drive evidence-based care in clinical practice. So check out READ for easy access to research personalized for you. Calculate for over 500 easy-to-use decision support tools, and Learn to earn CME online in minutes per day. Try them today at qxmd.com/apps. Again, that is qxmd.com/apps. So I've said this before, but I want to try to balance releasing both, just general critical care related topics as well as COVID-19 related information, as it's really kind of overtaken many of our lives in this, state of new normal. So what I want to do here today is, rather than focusing the episode on the actual treatment of COVID-19, talking about the experimental or off-label medications that we're using to help try to treat it and go through and dissect those trials. That's not what I want to do. What I would rather focus on is to talk about the new challenges of treating these patients while still delivering high-quality critical care. And so the episode is going to kind of be split into two parts with two special guests. So first off, the first guest joining me, I'm pleased to be joined by a special guest and friend of the pod, Drayton Hammond, who will be focusing on the critical care management of COVID-19 patients while they are mechanically ventilated. Now, this isn't not necessarily going to be going into ventilator settings per se, but rather talking about some of the principles that we need to treat and consider while they're on the ventilator. Now, Drayton is usually a medical ICU pharmacist at Rush University Medical Center in Chicago, though he, like many of us, has been a COVID ICU pharmacist for the past month. When he's not in the unit, he's actively involved in professional organizations such as FCCM and ACCP, conducting research and directing the institution's PGY2 critical care program. And we're very gracious that he agreed to join us today. So, Drayton, great to talk to you and have you on. How are you holding up with everything going on?
Yeah. Hey, Nick. Glad to be on the podcast. Big thanks for having me on. Regarding how I'm holding up, I think my response is probably similar to, all those other pharmacists that are in cities where COVID-19 has been hitting them really hard. The days are long, they're exhausting because our patients are so complex and their needs are so extensive, throughout the entire shift. But there are some nice silver linings to this entire COVID-19 pandemic. I'll say I've tried to view this, it's just an experience where I can learn a ton in an area that's super critical to our patient care and to our needs, and just, form even better relationships with the colleagues that I have in other professions in the medical ICU or COVID ICUs, I guess, as we're calling them, as well as those just across the country to try and provide the best care we can for these patients at the bedside. So overall, I think, it's a day at a time, but just trying to get through and do the best we can.
I think that's a really good perspective, because it's very easy to get lost in the day-to-day or to read, all of the, worst case scenarios, these projections, and feel very trapped or helpless. And it's a pretty slippery slope from there. So I think that's one of the things I've noticed with all of this is, you need to try to control the things you can control, because there's more and more in our day-to-day that is out of our hands, which is a new phenomenon for a lot of that.
Yeah, that's the truth. Positive attitude, support, and providing support to others. We've got a great group of colleagues across the country, whether it's on Twitter or, different, conferences, social hours that we try and do, respecting social distancing, just help each other get through this, because, we're all in it together. We need to try and do the best we can.
How would you describe your hospital right now? Do you feel like you're in the middle of the peak? because I know everywhere where I'm reading, and we're, for transparency for everybody, we're recording this on Thursday the 16th, so this will get released sometime the week after. But I know, right now, all we've been reading over the past week or maybe two is that Chicago's certainly an emerging, if not an already, hotspot.
Yeah, it's hopping here for sure. We're somewhere around the peak. Numbers fluctuate up and down, and we've got some great graphs for those types of things. But if we're not at the peak, we're maybe just a little bit over it for Chicago specifically, and then Rush as well. I'll say we've been pretty proactive as a hospital. We normally have about 111 adult ICU beds. We've opened up 3 other adult ICUs and only had to use 2 of them. Our PICU's an adult ICU now, and one of our ORs is adult ICU. So we've definitely ramped up services to try and provide the best care for these patients. And they're sick. I looked today in advance of us chatting, 72% of our COVID ICU patients are intubated, which is just insane. If you ever came into an ICU before this, and 3 out of 4 of your people were, tubed on all the stuff we're going to talk about today, it's wild, man. But as a city, we're doing well. We've done pretty good on social distancing. People weren't crazy on St. Pat. We got that canceled, so we're not nearly as bad as some other cities that have really been hit with that. We're worried about getting a second wave of patients who have all these comorbidities now. So I'm starting to see, your bread and butter NICU patients that also have COVID. So it's pretty wild, to be honest with you. But we're trying to get through, and we've got the right resources. So hopefully we'll get through the second wave and the third wave, and we'll take it from there.
And like you said, it's, it would be strange to see this phenomenon and maybe say you do work in, like a pulmonary or respiratory, like a RICU, for example, and maybe you do have a higher percentage of patients on the vent. I doubt that high percent of patients is all for the same thing. That's probably why it's just so striking is I'm sure there's times it feels like deja vu where you've said the same thing on probably 3 or 4 patients because you're rounding on so many of them.
Yeah, it's kind of tricky. I know a lot of our fellows at an academic medical center, we have, fellows and attendings in the whole 9 yards who are used to saying, oh yeah, this is the pneumonia patient, this is the DKA patient, this is the delivered disease patient. They're all the COVID patient. So it's a big role that our nurses and all of our, ancillary staff with RTs and pharmacy and everybody, just to make sure we're all on the same page. We remember issues from the patient from the day before and overnight. Just trying to individualize where we can, knowing that there are some things that are probably just best practices that we want to try and stick with, but best practices don't always work when you don't have drugs available or these people this is the area that we haven't really seen before. So we've got to pull a lot of tools out and figure out the best way to take care of these people.
Now, before we dive into some of the management strategies specifically for patients with COVID-19, I think it'd be helpful to maybe understand some of the practices you had, maybe still utilize for non-COVID-19 patients. So, generally speaking, what is your pharmacotherapy strategy when sedating or treating, pain, agitation, or delirium, treating those ventilated patients in your MICU?
Yeah. I'll say it's been almost a month since I've had non-COVID people, so I feel like I've almost forgotten some of the stuff that we wouldn't normally do. But I'd say, generally speaking, my practice is probably pretty similar to MICU pharmacists, around the country and probably around the world. We lean pretty heavily on our IV push. Fentanyl is our main analgesic that may provide a little analgesic sedation potentially just after intubation. We try and use pushes as long as we can. If someone needs a drip, we'll put them on a drip, but we want to try and reduce that exposure just so we can keep them as awake as we can, keep them lightly sedated if at all possible. And then, if we get to the point where we're going on to a fentanyl infusion, we start considering adding on a more traditional, IV sedative. So for us, it's Propofol or Precedex to maintain that light sedation. We're not necessarily sure the best people to use one drug in or the other. We're trying to answer that currently, but a lot of it's attending specific or patient specific, depending on how they present or how they're looking. But those are kind of our go-tos in addition to fentanyl. I'll say we got a little creative and with the help of some other pharmacists in the group and work with nursing and some of our physicians, did develop a nurse-driven sedation protocol that we've used for a little bit that did have IV push doses of benzos in it prior to going to these propofol or dexmedetomidine infusions, which I was trained that the right dose of a benzo is 0 milligrams. So this was a little different for me. But we've done some of that, and I'm sure we'll talk about later how we're really leaning kind of heavily on those in these types of patients. But we were using those to prevent synchrony, just low doses, trying not to do more than 5 milligrams a day of a benzo, trying to reduce the risk of them developing delirium. We do some weird things sometimes. You might get ketamine on select patients. You might do some other weird stuff. But for the most part, it was having your nasal sedation, adding on your dexmedetomidine or propofol as you needed to, and doing whatever you can to stay away from a benzo infusion unless their severe ARDS need to be neuromuscularly blocked, which is somewhat different from what we're doing nowadays.
It may be a hot take from what you just said, but the low dose kind of intermittent, as long as they're not getting it every hour or something, that tends to be something that I've done in the past, because sometimes if you have this uncontrolled agitation, they'll get they'll have that big code green episode where they're going a little nuts, and then they get really heavily sedated. So sometimes it's maybe a little bit of the hair of the dog, I guess you'd say, but I don't. Most of that data was with the infusions. So I don't think that's wrong by any means. Now, compared to what you just described, how has your management kind of changed with the COVID-19 pandemic? And I think maybe a better way of rephrasing this might be, if there weren't all of these concurrent drug shortages, happening at the same time, would you be doing anything differently?
Yeah, I'll definitely say it's not one of those, up is down, left is right. We're not forgetting these basic principles and it's more advanced principles that we have for providing care for mechanically ventilated, intubated patients. We're not necessarily doing silly things. Also, we've had to dig into our toolbox, maybe borrow some toolboxes from other areas at the hospital or from colleagues at other places that we try and figure out, based on what we do have available, what can we do? And yeah, unfortunately, drug shortages, or like issues with like distributing drugs to those institutions where the needs are highest for these challenging patients, are present, and we've got to work through them. So we do have some different strategies that we've tried to do. I don't know if you want me to talk about some of them in particular, whether it's different sedation regimens or just where do you want me to go from here?
Yeah, I think that would be great. Maybe giving just you don't have to necessarily go into the fine print of them, but to give us just a little bit of an overview, I think that'd be very helpful. Yeah,
sure thing. Well, it's for predominantly pharmacists that are listening, but whether you're another professional nurse, physician, PA, NP, RT, what have you, we all know it's a team effort. So anything that we do for pharmacy, whether it's at the bedside on rounds or if you're in an institution where you're not rounding, we've got to make sure that those people that are, the nurses that are in the rooms, the RTs that are going to work with the vents, understand what our plan is. So that's a big part of anything we do, is just make sure we're all on the same page, because we're doing things that we don't normally do in these patients. We've got to make sure we're all on the same page, same paragraph, same line, if at all possible. I will say for these types of patients, we are seeing that, we want to have the lowest, degree of, sedation that will help maintain them being synchronous with the vent. And that used to be, for most of our patients, light sedation, RASS 0, maybe -1, maybe -2. But for these patients, we're seeing a lot of them are just not being synchronous. They're dropping their O2 sat. And we've got to have them maybe at a lighter to moderate or potentially even a deeper level of sedation, which is something that, generally speaking, we had tried to avoid. So in terms of that, we're not necessarily going to fault anybody for saying, I need to have someone a bit deeper sedation, but we don't want to have, stuff that happened with the H1N1 pandemic, about a decade ago, where people were almost universally just, getting deeply sedated, getting snowed, because the propofol shortage. Benzo infusions were just rampant during that time. So we haven't had to go to that in almost anybody, which has been really encouraging. We're still trying to maintain that light level of sedation, but we are trying to spread out our drugs so we can get the most benefit or utility from them and the greatest number of people, which, there's ethical principles behind that we don't necessarily have to get into, but we're trying to do the best we can for each individual patient while understanding we have a population of, around 100 people right now in my hospital that are COVID positive. And, about 65, I think maybe 65, 68 of them today were in adult ICUs. So that's a lot of people we have to spread the resources out for. We know for these people, because the virus is just, wreaking havoc on their body in so many different ways, we're having to run their sedation a little deeper, like we said. So a common regimen for us, may potentially be, if at all possible, a fentanyl infusion. Though we can talk about, when we don't have any fentanyl, like we might have tomorrow at my hospital, just because we don't have it. Might have to be hydromorphone, low dose infusion with some reasonably dosed, PRN boluses, because if the patient has pain needs, we don't want to run them on a drug that's maybe going to accumulate, because a lot of them are getting AKI, ending up on CRRT. Try and give them some push doses so we can manage at the lowest rates of our infusions that we can, while still controlling the patient so they're not desaturating, not having issues like that. So fentanyl, hydromorphone are what we are trying to lean on our opioid side of things. We're doing those push doses of lorazepam like we talked about before. We find what dose works for them, and we try and stick with that, and we work with our nurses to make sure we know what that dose is. So that is pretty individualized to the patient, so we can gain control of them if they are getting dysynchronous with events. We don't have to go up on our rate of, propofol or dexmedetomidine potentially, or ketamine in some cases. So it's pretty multimodal. I think that's a word that comes up on almost every patient. It's a multimodal strategy for sure.
And it sounds like it's extremely patient-specific approach, because all of these are different, rather than, the ability to follow more of just a general algorithm. Like, you really have to kind of take time into thinking what'll work for each of these patients.
Definitely do, yeah. It'd be nice if all their organs worked really well and we had all the drugs, but neither one of those are the case. So we're very busy at the bedside, which is it's good, because it means that we're all learning and we're being able to individualize. But it takes a lot of brain power. It takes a lot of checking back, 2-3 times during the day, for sure.
And I think it's important to emphasize this multimodal approach, because, the easy approach, you're right, like you had kind of mentioned, that we want to avoid is just putting them on a benzo drip, right, and deeply sedating, and then dealing with all the problems that occur after that. And, it was interesting. I read a study from a French ICU talking about neurologic dysfunction, and somewhere between 60 and 70% of their patients had agitation or were CAM ICU positive. And then when you look into what meds they were receiving, over 80% of them had midazolam for a median of 4 days. So it's like, wow, the approach of trying to do multimodal and really a patient specific could have some really serious positive benefits in the long term here.
Yeah, it's something that we're very acutely aware of, whether it's just people getting, moderately or deeply sedated and increasing the risk for delirium, or maybe there's microthrombi and, cerebral arteries. There's so many things that are going on that we don't understand, but the things that we can control, the things that we do know from, years of critical care, we're trying to lean on those and do the best we can in those areas. So, we have some weird looking Mars. We've got, maybe 4 infusions and 2 different pushes that are going on there, and it's education and making sure the Joint Commission doesn't come, because they may not like some of the stuff we have in there, because it's just a challenge. But we work with nursing really closely hand in hand to try and do the best we can for them.
So a lot of our first line agents, kind of like you, a lot of the ones you described there for the treatment of PAD, they're going to be, or they already are, on some sort of shortage or back order. So have you all developed any, initiatives to try and conserve these medications? Yeah,
we're acutely aware that, we don't want to run out of some drugs if at all possible. So, the baseline regimen that we kind of talked about before, which is still individualized, patient to patient. There's some things we're doing that, maybe, I didn't do, a couple years ago. So, like I mentioned, Propofol and dexmedetomidine is drugs that a lot of our patients are on. And we know, from SPICE-3 data, there might be some signals for, hemodynamic instability when we put those two together, and we're shooting for like moderate step sedation. So we appreciate that those are some concerns. That being said, it gives us a very good way to use lower doses of propofol, reduce our exposure to a drug that, can cause hypertriglyceridemia on top of a disease state that already is showing, elevated triglycerides because of this secondary HLH that is probably going on in a lot of people. So we add a little Precedex to try and cut that propofol dose. And we're still minimizing our side effects. We're not using high doses of either, but we found that to be pretty successful in helping us get another, 2 to 3 days on our propofol for each patient. So we have something that's a lot safer, not going to accumulate as much. So we're doing our SATs right. So we've been doing that. It's a little different from not a practice we necessarily had prior to this in many patients. And then, we've had to try and figure out, the IV push benzos like we talked about, tackling agitation in those acute settings, especially whether it's, pumps are in the room versus out of the room. It might affect our decisions a little bit on like our management strategies. But for example, we almost ran out of fentanyl, about a week ago because everybody, and the mom's trying to order as much as they can above their allotment. So we end up, transitioning people to hydromorphone or to morphine. It was basically, a merry-go-round of what was coming in. And we finally figured out, let's just try and have, people, about 40% on fentanyl, about 40% on hydromorphone, and 20% on morphine. And that'll help us maintain our stock of all of them so we can shift if we need to. And then you've got to figure out, like, who's the worst candidate for this drug. They can't get that. They've got to get, like if you're on CPVH and you're on two pressors, you're not getting morphine. You're getting the fentanyl. Mm-hmm. If you're, early on, kidneys are great, not only pressors. You may be someone that we say, we can run a very low dose morphine infusion, give you some good push doses, so you're not going to accumulate it. And you're going to do fine on that, at least for a couple of days. And we obviously reevaluate throughout the entire day with our physician colleagues and nurses, but we're saying we don't have all these drugs. We have to find best ways to utilize the resources we have while doing our best to not put patients at, any harm that we wouldn't want to put them at because of possible ADEs from drugs. So it's an adventure every day.
That sounds like you're making a puzzle where it's like you have X number of patients each day, and then you basically start with the highest risk, and then you kind of divvy it up from there. It's like you're creating a pie chart or something like that.
It kind of is. It's like a Sudoku almost, where we have some capabilities in our AHR to get some reports and sort patients based on PDEF ratios and SOFA scores. So I know who I need to look at
that's
first in the morning. Helpful. It is, yeah. And if they don't get mentioned by anybody who talks about the response that we have to COVID-19, it'll be a disservice to them because all the order sets we built, all the discussion we've had, all the capabilities they've built into our EHR just to try and reduce the safety concerns that are already going to be there. It's just been fantastic. So that PDAP was built in like a day. SOFA was built in about a day and a half. So it helps us triage, helps us know where we need to look so we can tackle, their care first and figure out what do they need and then kind of go from there. So it's been a blessing for us for sure that was able to come through.
So are you using any other strategies beyond kind of the opioid rationing or opioid rotations?
Yeah, we've tried a couple things. So when we could count the number of fentanyl bags we had on two hands, we had to go to some intraoral oxycodone while we were transitioning people over to like hydromorphone infusions. And it was okay for a few days, but when you're, running somebody maybe at, 200, 300 a fentanyl, that comes out like 900 milligrams of oxy in a day. So we're not going to put people on doses like that. But even if they're on 30 or 40 Q6, that's going to accumulate after a couple of days on many people. So we've tried to really shy away from that because we've done some conservation with, reducing our exposure to opioids, realizing this is more of a sedation issue and just a little bit of pain we need to tackle. So we're using lower doses of those now, leaning our sedatives more, and that's helped us preserve some of our opioids, so we're not having to do the intraoral oxycodone anymore. We haven't gone to crazy stuff like fentanyl patches and people on stable doses. With all the fevers, I don't even know what the variability would be in drug they would get. They might, get overdosed just from that. So we've been able to avoid some of the things that we just absolutely don't want to do, but the intraoral oxycodone was one that we probably leaned on, and we've pulled some triggers on adjuvant agents like Tylenol and some of those that aren't going to accumulate in renal dysfunction. Like we're not really leaning on gabapentinoids or things like that because we worry about the oversedation that's kind of tougher to control with the longer half-life. But we still had a couple tricks up our sleeves that we're trying to use.
Have you had to resort to any of like the fentanyl analogs like remifentanil or sufentanil,
Yeah. We've got a Remy build in our EHR that we're ready to pull the trigger on if we have to. But we're like our anesthesia colleagues are obviously much more familiar with Su and remifentanil, and they're involved in the care of these patients, but it's predominantly our medicine group in pulmonary care, cardiology, and even nephrologists who are attendings with home care fellows, which is kind of wild. So we haven't necessarily leaned on the Remy or fentanyl yet, just based on still having drug in stock. They're not exceptionally comfortable with that. And if you were to run out of that, because it's those short half-lives, worry about, people just doing poorly on the vent when they're, waking up. So we haven't gone to that yet, but, if this lasts, another month or 2 months, we're going to do whatever we have to do. That's going to be on the table for sure.
I want to bring back something you said. You're exactly right. Everyone who's still working, from, anyone who's out there, deserves some praise, but especially in the healthcare world, our IT colleagues are definitely underpraised and underrecognized, because just like you said, like, imagine if, these drugs went on shortage and you were trying to use, say, remifentanil with no EHR record. That's basically impossible in today's world. I mean, it's not impossible. Like, of course, we'd be able to figure it out, but the risks of errors, all the things that could downstream happen because of that, with everything changing due to shortages and everyone having to quickly adapt, the IT world has been a godsend.
Oh, yeah. No, we would figure it out, but unfortunately probably be on that first patient that gets it, that doesn't get the right dose, and we're like, oh, my goodness. So, yeah, we'd rather not do that if we can. So IT, big props to them.
So how are you attempting to manage your Propofol supply? I ask because if that white gold runs out, things certainly can get a whole lot more complicated in terms of sedation management, can't they?
Yeah. So we've done a couple things, and then there's some that we've considered and we haven't quite moved to yet. So one of them is because we have moved many of our IV infusion pumps and the poles they're hanging on outside of the room unless people are hemodynamically unstable, then we try and move the pumps in so we're not titrating pressors and 46 mils of tubing. That's not the best idea. But when the pumps are outside, we have looked at extending that tubing from changing every 12 hours to changing every 24. We did that initially, and then just because of possible safety concerns, we've kind of moved back to trying to do it to Q12 hours and trying to have those pumps in the room so we're reducing the loss of propofol. That being said, those institutions that either have made that change or are considering it, I would just caution you to remember that all the data for the PI for propofol is from multi-use vials or from syringes. So when they're saying 12 hours, it's not in the way that we're currently using it. And we've tried to contact and talk with manufacturers just to get anything that can help us feel more comfortable about extending the tubing beyond 12 hours. So I'll shout out to the UPenn group, Megan Kaler, Jamie Gray, and even a PGY1 there. Sarah Knob made some calls along with me, emails, try and get any data we could to feel more comfortable about extending beyond 12 hours. They didn't have the data they could share, so we ended up going back to 12 hours for our bags, or for our tubing. But for those groups that are doing it, this is a pandemic. We have to accept some risks to try and provide the care that we need to provide to these people. And then the other one that we are probably about to start doing, we're already not using propofol in our RSIs if we can help it. One, for hemodynamic instability, and two, we know we might have to use those 20 mil vials and just use those to prime tubing. Probably not going to be able to hang drips with them, but you can prime the 26 or 38 cc's and these tubings with those 20 mil vials pretty well. And I think there's a pretty cool picture from, I think it's Kim Ackerbauer in Boston where he's priming some tubing with it. And yeah, I mean, that's still propofol. It's still going to work. You don't want to change the bottle every, 10 minutes necessarily, but you can prime tubing with that, just fine. So I think it's something that we're probably going to have to pull the trigger on if this goes, another month and a half, 2 months. But we haven't done that yet. We're trying to reduce that use in other settings that aren't as essential as continuous sedation.
Now, recently, the pharmacy and the critical care, listservs, they have been on fire, talking about hypertriglyceridemia and, when to switch off or reduce our propofol infusion rate in these patients. So what's your personal practice, and is there much literature to support really anything on this kind of specific question? Yeah,
that's a good one. They've definitely gone deep in the discussions. I feel kind of bad because I started one of the two on a lister, so sorry about that, guys. So I'll confess that I'm probably a little more cavalier, a little more of a, I don't know, just shooting from the hip on this one a little bit. I've been using a cutoff of 1,000, since I was in residency. I had great discussions with probably the most brilliant NICU pharmacist I know, Jason Ferreira, about some of the data. The one in particular that really leaned me towards the 1,000 cutoff was the Devlin article, 2005, pharmacotherapy, way back, long time ago, where they saw very few cases of acute pancreatitis developing, and their average triglycerides in these patients, were about 750, 740, something like that. Two of the cases that had it out of, almost 200 people were at about 1,000 to like 1,400. So I was like, this is a drug that is exceptionally good in our patients who are mechanically ventilated and need, whatever level of sedation you need. You can just titrate it and get there. So I've done that for the last, 8-9 years. Never seen a case of acute pancreatitis. Now, I'm a MICU pharmacist. I'm not in the SICU or some other areas where maybe they might be at a little higher risk. But, that's the cutoff that I use, and it's served me well. And it gives me an extra few days on propofol in these patients, and I haven't had any issues. So that's what I'm running with.
I feel like a wimp now. I always have my red flag. I put my hand, the flag up at around 500. I'm batting 50% of that. So I feel like I'm going to have to reevaluate my current strategy here.
I'll confess you're probably with the majority with that number. But I mean, we do have data from Aspen says 1,000 is great for, their lipid infusions that we're doing. And it's not like we're doing hey, you're on this infusion, I'll just check our triglycerides when I get to it. Like, we are doing it every 48 hours. If you've got a value, it's above 500, and you're early on your phase looking very sick, then I'm going to do it Q24 at that time. Because, we don't want to cause an issue when we do have some other agents, but like I said, we're running these adjuvants to try and reduce our propofol exposure, trying to maintain them at the level of sedation that we do need them at, and we're getting an extra few days out of the propofol with this. So I'm gonna go with it. It's been good so far. You'll probably get comments in the chat about this or whatever, but it's been fine so far. So I'm gonna go with it.
Now, how about the risk of PRIS, or for those who may be unfamiliar, the propofol-related infusion syndrome? So, have you encountered this, or are you expecting to see this in COVID-19 patients? Any more than just general critical care MICU patients like you were treating, pre all of this?
Yeah, so I guess I've been pretty fortunate. We know the epidemiology is probably 1 in 1,500 to 5,000 patients. That's a lot. I've seen 2 in my career. One was super high doses of propofol for a TBI or super refractory seizures. Those are not these patients, thankfully. The other one was just a normal MICU person who had a couple risk factors and just bad luck, maybe some gene ribosomal stuff going on. But I don't think we know enough about COVID-19 to really figure out, like, where do you plot this on the more likely, less likely continuum. But, we're on the lookout for it. We do a lot of ABGs. People, we know their pHs. We're checking a lot of labs. So, I mean, I would be very surprised if we were to miss, knock on wood, an early presentation of this. But it's tough to say if they're more or less likely. So we're just going to try and be careful and do the best we can for them.
Yeah, that's a really good point you made in terms of the monitoring, and I would say that that's one of the few bright spots from this, is kind of when you're not 100% sure what the course might look like or what might happen. You're going to do a lot more frequent and maybe in some cases aggressive monitoring, and it sounds like in these cases it's 100% appropriate, so that nothing's slipping under the rug in any of these patients or anything.
Yeah, we're trying. We're bundling our labs. Big respect to lab and to nurses, because they're on the most front part of the front line. So we're doing the things that we need to do, and we have rationale for everything. And we're doing a lot less of our tests that maybe we didn't need before, because we know that we don't want to bleed them dry with all these sticks, and we don't want to put people at additional risk and use PPE if we don't have to. So it's a balance for sure.
Oh yeah, we love our nurses here. Absolutely,
we do.
Now, another agent that can certainly have a role for for sedation, but maybe has some safety concerns, and you mentioned you're using it in a few patients, is ketamine. Now, Would you say that you're using ketamine more just due to the rationing of other sedatives maybe than you would have typically used otherwise?
Yeah, I think that's a great way to describe it. I mean, we definitely used it in many patients before. We're not using it like the University of Cincinnati people are. Chris Ferrer, who's probably going to listen to this and say everybody deserves ketamine, but we are doing it in a lot of people who, the way that they're going to stay this event is with moderate sedation. They don't need it for light, so we're not pulling the trigger on many of them, and it's probably not going to help us with the deep sedation, but we are doing a lot of our moderate people. It's helping us reduce the amount of propofol we need. If their triglycerides come back at 1,200, we might have to go with like a dexmedetomidine, ketamine, push dose of benzo type of plan. And we've done that on more people than I could have said I'd done on a month and a half ago, and it's working for most of them. It's not a benign drug, so I mean, obviously we're not worried about like the viral cardiomyopathies, dysautonomias that some of these people are getting. Like, we're vigilant. We're, if we go on pressors, we're just trying to monitor everything. We're trying to be careful with it, just like we are with all these drugs. But it is in our toolbox, and we are using it.
In our attempt to preserve PPE, one of the more problematic side effects from ketamine would be the potential hypersalivation. Now, are you seeing this at kind of the lower doses that you described? Are you pre-treating patients to maybe prevent this?
Yeah, so for ketamine, for sure, we are using it more than we did before. I'll actually say that prior to me calling in to chat with you today, we had a patient who self-extubated, who was not on ketamine, but these tubes are just really slippery in the tracheas because they're already having hypersecretions at baseline because of the disease state. So we are acutely aware that ketamine can cause some of that hypersecretion occurring or hypersalivation in patients. We're not shying away from using the drug on people, but we are making sure anytime we're like proning or supining a patient, we're making sure we know where the ET tube is, before and after that repositioning, especially if they're on ketamine, just to make sure we don't lose it and have an acute event where we've got to reintubate someone pretty quickly. So we're careful about that, but we're not doing anything to try and dry up secretions because we're seeing these people are at risk for, a ventilator-associated pneumonia, somewhere in that 10 to 14-day range, just like our people who are on the vents for that long or without COVID. So we don't want to dry up secretions, maybe put them at greater risk for pneumonia. So it's a balancing act for sure, but we're just trying to be cautious with them and just monitor, good bedside care as best we can to try and catch that if it is an issue. We haven't had to switch anybody off of ketamine yet, but we do have some concerns looking at, when we're doing our SPTs, looking at extubating them. If there's a lot of, secretions, hypersalivating, we're probably not going to extubate them on ketamine, for example. We may, put them on dexmedetomidine or just go without any drugs on board and extubate them in those situations. So we're looking out for it, but it hasn't really affected our care too much yet, thankfully.
Yeah, and you mentioned trying to keep them dry, and that that also kind of corresponds to just their fluid balance, and that's kind of another mini concern with ketamine is some of these patients just getting fluid overloaded from the sheer amount of volume that they may receive. Have you all made any changes to your kind of ketamine infusions to help counteract the potential fluid overload that could occur because of it?
Yeah, so our first couple days when this was all starting, the using ketamine, we had just a 2 milligram per mil concentration. We realized real fast that was not going to work. You're looking at 3 liters of fluid in someone. So we already had a build of 10 milligram per mil. That was our stats epilepticus build for ketamine. So we just transitioned over to that, had the drug available, and we're still able to get it, thankfully. So that's our standard concentration for ketamine in all these people. So you're looking at, maybe 500, 600 mils a day, which is nothing to be like, oh, that's a low number. It's not. That's half a liter, and someone who would love to not have that half a liter fluid. But it's a lot better than 3 liters, and that's only at the highest rates. A lot of the rates we're running them, like the 1 to 1.5, we can get by with giving them less fluid in a day, which is good for sure. And then I'm thinking just, off the top of my head, we talked about hypersalivation and fluid overload, but another one that I hadn't appreciated was as common as maybe it might be is, these drug fevers. And we already kind of knew it with dexmedetomidine, but we've seen a couple people that have actually had one with ketamine. So it's on my radar more than it used to be as well. We're not running to it first. Yeah. We're not saying, oh, this patient's, up to 103 on day, 12 on the vent. This is the drug, but we're still learning about this disease state. We're using drugs that we aren't just familiar with. There's not great epidemiological data out there for dexmedetomidine drug fever, ketamine drug fever. There probably will be after this, but we're looking out for those as well. So it's on our radar. I'm sure it's on every other pharmacist's radar as well, but it's a little more acutely something that I evaluate than, maybe I did prior, just because, I didn't use ketamine more than maybe 50 times before this, and I probably got it another 50 times in the last month. So it's a little more acutely aware of it.
You've earned your Chris Droege ketamine certificate.
I hope so. I'm expecting one at the next meeting I see him at or in the mail. Yeah.
I think he's probably got like a universal database where once he figures out that you've treated X number of patients with ketamine, he's got a little red light bulb that goes off and he knows to send them out.
I'm assuming they just send him a report every night of who've used it, and he just is storing it all on a server somewhere. Yeah.
Chris, if you're listening, we're just giving you a hard time here, my friend.
I'm sure he'll call me.
Now, drug shortages are affecting everything. Like you've mentioned, we've been focusing on sedation, pain, agitation, delirium here, and they've reached our neuromuscular blockers as well. And with these patients and their presentation kind of having it have such stark similarities to severe ARDS, I imagine that, like you had kind of hinted on, many of these patients need not only deep sedation, but possibly paralysis. So in the efforts of conservations and just the sheer number of patients, what has been your general practice regarding paralysis in these patients?
Yeah, I'll definitely say I'm at an institution where we're probably not prior to COVID-19. We weren't pulling the trigger on continuous infusion, cisatracurium quite as quickly as maybe some other institutions that I've worked at or have colleagues at, but we were still using it maybe more than the data would suggest. And we had thought about as a group about transitioning to push dose cisatracurium prior to this, but hadn't pulled the trigger because there wasn't a need to, and we're all busy with other things. But yeah, within a week of this COVID-19 stuff happening, we'd already worked with a couple other pharmacists here and built out a whole module for IV push dose cisatracurium, using it only obviously in those patients that are deeply sedated, making sure we have RT and nursing and our providers, either attending or a fellow, aware of when we're going to get the drug, what we're going to assess to figure out, along with ventilator setting changes and looking oxygenation, like, did this work or not? And if it works, great. We might not have to get the drug again, but if they desaturate, get desynchronous again, we're going to give another push dose. And these are 15 to 20 milligram doses. Unless you're a really small patient, then it might be a 10 milligram dose. Vial size is 20 milligrams, so it's nice that those weight-based doses kind of work out to that. But we're going to give patients every chance to demonstrate that the drug actually works for them before we put them on an infusion. And we're finding that a lot of them, unfortunately, it's not really moving the needle on their oxygen stats or on the dysynchrony or on their PDF ratios. So we have far fewer patients today. I think we have one patient in my unit on a cisatracurium infusion and 3 others that are like getting push doses as needed at a 28 beds, compared to week 1. I think I walked in and got a call because we had 8 people on cisatracurium infusions, and they said, we don't have enough drug to make these right now. So it's very different. And we ordered up and we got some in, and we thought about other options. We have a build for rock just in case, but we haven't had to pull that trigger yet, which is nice because we're seeing some liver dysfunction in these people, and just safety-wise, it's great to use a drug and can kind of trust, and it's going to get cleared one way or another. But we're not doing it as much as I thought we would, and it's fortunate because it's not working for many of our patients.
Unless there's an unexpected breakfast that you didn't know about, starting your day with a call from the central pharmacy about a drug order is rarely is that a great start to the day.
No, can't say I was like, oh, thank you so much for this call. It was like, okay, we have to tackle this like right now, pretty much. So, and the nice thing is, because we're rounding services, the team I'm rounding with, I can say, this has to be something we talk about on everyone in patients. And then I'd go to the other team and let them know that I'm going to run the list with them, and we have to make a couple changes. We all work together as a team, so we got it done. But yeah, you don't want to receive that call, of course. We have, I meant to mention, we were previously an institution that titrated cisatracurium infusions to Trainor. We pivoted off of that and went to just flat dose used from Acurus and Rose. But then when this started, we've actually gone back to titratable based on ventilator dysynchrony. So really leaning on the RTs, nurse, and physicians to be able to assess that and make a change off of that and titrate up or down based on that. But that's probably, a quarter to a third of the drug use compared to a flat dose. So in the patients we have had to use an infusion in, that's worked really well to preserve that 200 milligram bag much longer than it previously would have lasted. So that's been very helpful.
And the titration to ventilator compliance versus Trainor is probably a really unique way to help conserve some of that drug. So I think that's good for in kind of a twofold way there. Yeah,
and I mean, we're already assessing these things, so we might as well just use that information and try and just provide the best individualized care we can for a patient.
Mm-hmm. Now, you hinted on this, and I kind of want to dive just a little bit deeper into it. Sedation and all of these titratable drips, right? They require nurses going in and out of rooms, donning and doffing. Have you implemented anything? And maybe it sounds like you have, so maybe go into a little bit of detail as to help reduce the amount of time that the nurses and the team need to enter the room, kind of to save some of that valuable PPE.
Yeah, I'd say the only thing more important than the drugs we have is the personal protective equipment. And I think anybody who is going to these rooms for whether it's code situations or just any reason knows just how precious that is. So we feel for our nurses. We've talked with them. We had the pumps inside the room, and then they got moved outside the room to try and reduce having to go in and exposure and PPE use. We obviously realize that if it takes 3 minutes to 5 minutes for drug in that tubing to make it to a patient, usually that's fine. It's situations where, stuff hits the fan and it's not fine. So sometimes we've got to move the pumps in the room if we're like in pre-code, slow code, or a true code situation. We'll do that. But as an institution, we've kind of really gotten behind our nurses and said, we value you as being the front line of the front line for this. So any patients that we can, we're going to have most of our infusions outside of the room. Those that aren't titrated, those are fine to have in the room because you're not going to touch it really. But we've really respected, just them and kept stuff out of the room if at all possible. It's mostly fine. When it's not, we pick it up pretty early and we move pumps into the room. So we haven't had like events from that, thankfully, because we have great nurses and we're all very acutely aware of looking out for that. But it is a balance. We lose a little extra drug from tubing exchanges, but we feel like we'll make that work.
It's, you hear 3 to 5 minutes, and when we're outside of the unit just at home, you're like, oh yeah, 3 to 5 minutes. But then you put yourself in that room where you're looking at that blood pressure or looking at that agitation. Suddenly 3 to 5 minutes feels like we're needing to run a marathon to get this started.
Yeah, it's tough. We do this. I mean, this happened on rounds today. Someone was, not to get off the station topic, but, a low to moderate dose of norepinephrine, dropped maps a little bit, went up, didn't see an effect, went up, and then we came by the room and we're like, that's a lot higher dose than what we were on when we pre-rounded. And the next thing you know, the map is, 115. You're like, okay, let's come back down slowly. We don't drop it back. So we've gotten a lot better about, titrations every 3 to 5 minutes. To give a drug a chance to actually do what it's going to do or not do what it's going to do. But it's a different culture because usually you can titrate every minute and you're going to see an effect. So we're all learning on that for sure.
So we've kind of been focusing our discussion on the, management of patients that are concomitantly mechanically ventilated. I think another medication that is just commonly used, in these patients is our bronchodilator, right? Albuterol. Have you started limiting its use for conservation purposes? Because, I think at least at the institutions that I worked before, I think, we commonly just prescribe them the moment they put the ventilator order set. Everyone's got scheduled nebs, whether it's albuterol, the combination ipratropium, albuterol, regardless if they have a true indication or not.
Yeah, so I think our first few days to week. We were similar to probably every other institution where they were on, Q6 nebs, and then we realized, oh wait, we probably don't want to use nebulized drugs in these people if the circuit breaks or whatnot. So we went to MDIs, but then after that, probably a week and a half to 2 weeks, as we learned more about their pathophysiology and what was working and not working, that the bronchodilators just didn't seem to move the needle on anything. So we've kind of gone away from having them in patients unless they have, concomitant indication, like maybe they have some IPF or COPD and their exacerbation plus the COVID-19, then, they've earned themselves some, inhaled bronchodilator. But we're MDIs just for safety of, RTs and nurses that are going to be in the room administering those, or if circuit breaks or whatnot. But we're not using much of it at all because it's just not working, unfortunately.
And I've been reading that some of these patients, they can also develop like microthrombi in their lungs. Mm-hmm. So have you implemented or had the initial kind of discussions on using any type of inhaled heparin or, maybe another anticoagulant?
Yeah, we're in discussions. This is go do your PubMed search and try and find good data on what to do on this, right? But that's everything with this disease state. And so we've talked about inhaled unfractionated heparin. We even talked about low dose inhaled, like alteplase in these patients. We haven't pulled the trigger on them. We may look back and say, gosh, that was a missed opportunity. And we probably could have helped some people out. Or maybe 2 weeks from now when some stuff gets published and we're like, okay, we're going to do it. But it's not something we've implemented quite yet. We're doing a lot of other crazy anticoagulation stuff, but that's not one we're doing yet.
And, when we read or hear like it's developing microthrombi in the lungs, like, do we think that's kind of like those severe HIT patients where they're throwing these microclots? Is it like a similar kind of etiology of their microthrombi?
I guess I wish I knew.
Yeah, okay, that's a better question. Do we know?
Yeah. No, I mean, we're running so many anticoagulants to try and figure these types of things out. It's probably not that type of picture. It's not an exact TIC picture. There's some weird stuff going on here for sure. We definitely are at the point where we feel like, if it's an organ, it's got some degree of microthrombi in it. It's probably explaining a lot of these AKIs, a lot of the lung stuff. Maybe even people aren't waking up because they have microthrombi and, cerebral arteries, might be having some minor MIs from coronary arteries. Like, this is probably going on in patients. We're not at the point where we're, running low-dose TPA infusions and people, but we're acutely aware that, this is probably some component of the pathophysiology. And we're hopeful that someone, if it's not us, someone else will figure out what might be working for these patients. Because, we're just not certain quite yet.
So have you had any success with using inhaled pulmonary vasodilators such as, epoprostenol or nitric oxide for the, just acutely and severe hypoxia that these patients experience, kind of like a Band-Aid while you're trying to get everything else in the works?
Yeah. I won't say that we've leaned super hard on like inhaled epoprostenol or inhaled nitric oxide. We know there's some like INO data in MERS. This is not MERS, but there's some data in that disease state that was affecting the pathophysiology in a positive way. So we're hopeful that maybe we're doing some good in these patients beyond just making our numbers look better. But yeah, someone who is synchronous with the vent, but they're not having, a good P to F. We're having to run, RFO, who's a little higher than we want to. We've put some inhaled EPO on those patients, and we've seen a positive effect. More than half of them, we're looking internally to figure out, trying to figure out who maybe deserves it and who's benefiting from it. And we're seeing some encouraging data, but I couldn't tell you today, this is the person to use it in, this person not to use it in. It might just be making numbers look better like it usually does in ARDS and not have mortality benefit. But we are doing it just to try and reduce possible oxygen toxicity or just run our PEEPs a little lower so we don't have those potential complications we think might be occurring from really high PEEPs in these people. But we don't know yet either.
So I imagine there's many listeners who are maybe seeing small numbers of COVID-19 patients start to trickle in, or maybe it's a little bit of like the calm before the storm. What would you say to those pharmacists or other healthcare providers about any type of advice for helping manage or prepare for these critically ill COVID-19 patients?
Yeah, I would definitely say just general advice. One, it's probably going to be a marathon, not a sprint. So if you can focus your efforts and energy on just positive collaborations and then just preserving yourself and your colleagues and your friends, just generally speaking, I'd say those are good strategies. But in terms of like maybe some of the specifics for that, like whether that's collaborating with colleagues for multiple professions at your institution, develop strategies so people can understand what they're doing and feel more comfortable and confident with the care they're providing. Working with, whether it's pharmacists or physicians or PAs, NPs, whoever at other institutions, sharing resources, being on the listservs, being on the Twitters, just supporting each other in that way, I think can be really helpful in terms of providing that care, but also those are great outlets for building relationships and then people that, if you don't understand something, you can ask them and they might have seen it and they might have had a good experience or they had a bad experience. They can tell you like, don't do this because, it just went so horribly wrong, and you can try and learn from them and you can support them and they can support you. It's been really helpful. I will say as an introvert, it's not as bad of a time as maybe it's for those extroverts who are, in their homes and probably doing the house party app every night with friends. But I've been very fortunate to have a good group. There's about 13 or 14 of us that, do a weekly, we'll call it conference call, but it's basically a happy hour where you just talk socially distant, of course, over a Zoom. And we talk some COVID. We talk a lot of non-COVID. And that's been super helpful. So, if you do get into the throes of this, support isn't just, and taking care of the patients. It's taking care of yourself is huge for sure. I can't really overstate that because we have no idea when this is going to end and what it's going to look like and all the ebbs and flows. If people start going out again and they don't have masks, who knows what could happen here. So just trying to take care of your mental, physical, emotional needs. You can provide good care to patients. You can be a good team member. You can give these patients the best chance to have a good outcome because you're able to be present and not be burnout and not be exhausted. I think is super important for anybody who might be getting into this or is already into this for sure. And then we know the best answers to these are going to be RCTs. As a pharmacist, it's tough to do those, but I know there will be some observational, studies that'll be done. I know that Megan Reck, Tom Yano, and I are going to run one. So if you're a site that wants to contribute to that retrospectively, please reach out. This might be an annual thing. We don't know. So getting the answers to some of these treatment questions or even just some of the safety and efficacy questions for the agents we're using, the other strategies we're using, it's not going to hurt us to have that knowledge for sure. So on like the patient care side, hopefully we can do that as a group. And then on the personal side, you got to put your mask on before you can put someone else's mask on, right? So you got to preserve yourself and take care of yourself.
Yeah, self-care is incredibly important in this time. I think that's a really good emphasis point you had there because if you're not taking care of yourself, it's going to be hard to take care of others with how everything's going.
Yeah.
Now, let's end on some a little more lighthearted or kind of funner questions. So I know you're a big baseball fan. I know you frequently travel to some stadiums. So what's your favorite stadium or ballpark that you've seen a game at?
Oh my goodness. Well, I haven't hit them all yet, so this answer could change in a couple of years when we can go back out to sporting events. But out of it's like 22, 23 I've been to, it's probably two of them. So I'm not a Pittsburgh Pirates fan, but their stadium is just beautiful. Three Rivers, all of that. I remember visiting for a couple games, and the games were great. The area was great. Had a great time and just beautiful. I am a Braves fan. Been a Braves fan for probably 25 years or so. So I was very fortunate to be able to go to the opening weekend when they opened their new stadium, SunTrust Park, and it was wonderful. We won all the games, so that was great. But it was just so clean. Everybody's excited. Great atmosphere. So that one's probably going to be tough to top. But I'm I'm gonna keep looking, see if maybe I can at one of these other stadiums or just hit some of them again in the future.
Yeah, I'm glad you gave both options there, because I was going to tell you can't answer the Braves. I know you're a Braves fan, so I know that was going to be an easy setup there. When we're hopefully able to go back into stadiums, PNC Park for the Pirates, and then I think it's called Oracle Park now for the San Francisco Giants. Both of those I love, because when you're behind home plate, you see the view of the city and just everything, and it's just, the view is second to none.
Oh yeah, I will say, if you're listening and you do go to San Francisco, I went there and got a nasty sunburn because you're right on the bay and you get that wind, so you don't think, it's super sunny, but next thing you know, you're like, I'm like a lobster. Like, what happened here? So be careful. Wear your sunscreen, wear your hat. Yeah.
So I have to ask everyone who's from Chicago who comes on, I have to get their opinion. So do you like deep dish? And then, even if you don't, I think you have to tell us what your favorite or what would just be the default number one Chicago deep dish spot if you had to choose.
Yeah. So as someone who's not a native Midwesterner or a native Chicagoan, I said, I've got to try this. I do normally like pizza. I will say that, if given the option, I'll take deep dish because it's delicious and you can fit so much in there. In terms of favorite, I haven't had every single one, so I'm probably going to offend somebody on this. The Giordano's is the one that I've enjoyed the most so far, so I'm gonna run with them, and haven't done me wrong yet. So.
Well, that's one of the top three. That's definitely. Yeah.
I'm probably safe from a third of people at least.
And then, as I've been saying, I think for the foreseeable future, I'm going to ask all the guests for kind of a quarantine entertainment recommendation. So whether it's a movie, a TV show, or book, what kind of recommendation do you have for the listeners?
Yeah. I will say it does help me unwind to do, the Netflix and those types of things. So, if you're into those types of things, Altered Carbon and the new Ozark seasons were very good. If you like the previous seasons, I think you'll enjoy those. So I've knocked those out just, before bed to try and unwind a little bit. So I think those are probably my go-tos so far. And if you're into nerdy stuff like me, board games, card games, they've got so many different apps you can play with friends that are free or very low cost. So it's a great way to still connect and kind of get that side of things in. Whatever you like to do, I'm sure some smart developers has found a way to have that for you. So just lean into that. Just try and take care of yourself, whatever works for you.
That's a great statement there. You're exactly right. Whatever you're into, if you Google it, there's probably a way to virtually do it, at least to some extent. Well, Drayton, thank you. Thank you for your time. I can't imagine how busy you are with all of this. So I really appreciate you joining me and really helping talk about some of the things that you've dealt with and some of the issues that you've identified and helped solve, because I think this is definitely going to help some of our other listeners in hospitals who maybe don't have these same numbers or maybe same kind of resources. So thank you.
Yeah, I appreciate you having me on. Like I said, these are things we found things have worked. We found things that have not worked for us. Your patients may have different comorbidities. They may have different people that are available to take care of them. So just reach out to people if you're uncertain. We have the listservs, we have social media. I'm sure you've met people at meetings, so just lean on people. Nobody's going to feel dumb for asking questions because nobody knows anything about this. So,
yeah, if someone wants to get in touch with you, what's your Twitter handle for the listeners?
I tried to be witty with it, so it's Dr. Dre with a DRX, DRAY. I'm doing what I can to try and be hip with the youth.
I feel like we needed the Still Dre piano intro when you said that, right? That iconic.
Yeah. If you can fit that in there, I won't stop you. Go for it.
Well, Drayton, thanks again. I really appreciate it and appreciate you.
Yeah, thank you so much, Nick. I love the podcast, so thank you for doing this for all of us. And thanks for mixing in the COVID-19 and the non-COVID-19 stuff. It helps us provide better care and just kind of get through all this. So thank you as well.
Yeah, I appreciate that. So another massive thank you to Drayton Hammond for his time and expertise. But now I'm very fortunate to have Peter Nikolos joining me to discuss the critical care management of COVID-19 patients, focusing on the cardiac side of things. We'll be talking about vasoactives, anticoagulation, thrombolytics, and more. Now, Dr. Peter Nikolos is currently an assistant professor of pharmacy practice at LIU Pharmacy and practices in the cardiac care unit at New York Presbyterian Weill Cornell Medical Center in Manhattan, New York. He received his Doctor of Pharmacy degree from Temple University School of Pharmacy in Philadelphia, Pennsylvania. He completed his PGY-1 pharmacy residency at Temple University Hospital and PGY-2 critical care pharmacy residency at Temple University School of Pharmacy. His areas of interest include sedation and analgesia, antithrombotic therapy, extracorporeal life support, and infectious diseases. And he was extremely grateful to take some moments out of his chaotic and busy day to join in us. So Pete, thanks for taking some time for us today. How are you doing?
I'm doing pretty well. Thanks for having me on the pod, Nick.
I think everyone has read or hopefully seen some of the video from the New York hospitals that have been released in various medias, and it's both simultaneously eye-opening and heartbreaking when you look at some of the things happening. So how are you and your loved ones holding up?
Yeah, so the last month and a half or so has been pretty crazy here in New York. Things have evolved very rapidly, both at the institution, the university that I work for, as well as just personal life. Everything has seemed to flip upside down, and we're dealing with a lot of challenges up here.
Now, before kind of getting into some specifics, I guess hopefully you've been able to feel the love from just everyone across the country. If they haven't been able to go, if we don't live in New York, voicing their support. I've seen the videos of the people cheering at shift change, and it's just those are the types of moments that are really good. But I hope you've been able to feel the love and support, from across the country with, the focus being so much on New York right now.
Yeah, I think New Yorkers are definitely feeling all the love. It's great. Down in the city, I live in Queens, but in the city every day, I believe it's at 7 p.m., people are just going out on their balconies and clapping and making noise for all the healthcare heroes that are working in the city. Which I'm sure everybody appreciates.
Yeah, it's always we don't do what we do for all of that, but it's certainly nice to feel it in times of need like this. So within kind of New York and your hospital, what types of shortages have been occurring so far? Because I know PPE and ventilators certainly have been getting most of the mainstream media attention, but what about medications or even staffing? Is it affecting basically everything at this point?
Yeah, I'd have to say that, I haven't been focusing on the PPE or ventilator side of things, but from a medication shortages standpoint, we've definitely had to deal and be kind of, creative with our choices in therapy due to these shortages, specifically with some of the sedatives. We've been dealing with a big Ativan shortage at our hospital. So those patients who can no longer tolerate Propofol due to high triglycerides, we're having to switch them to a benzodiazepine drip, and midazolam is pretty much the only one that we have next. Fentanyl, we had a shortage of. We've acquired more, but for a certain period of time of a week or two, we had to transition patients from fentanyl drips to hydromorphone drips. A lot of these patients have been requiring paralytics to help with their oxygenation, and we have a massive cisatracurium shortage. So we're primarily just using rocuronium as our paralytic of choice. Those have been some of the main medication shortages, along with IV amiodarone, some of the antibiotics, and then norepinephrine being our vasopressor that we've had some issues getting in and having to compound in-house due to our outside vendor. But it's definitely affecting our management of these patients.
And that is specifically why, I asked you to come on, because you're exactly right. We're having to get very creative and kind of pull out some tricks from our bag. And so hopefully you're going to be able to help us in that arena there. Now, are you still rounding in the units, or are you remote at this point?
So I haven't been rounding in the unit physically. Last month, due to the banning of students from sites here in New York, my site being one of the first ones to do so, I had to actually continue the rest of my students' API rotation remotely. Luckily, we got their remote access to finish out their rotation. But due to all the changes at both the university and the institution, the best plan that I could come up with to manage all those things was to go remote, which has been working out pretty well for the most part. But as you can assume, it's pretty challenging managing a service of 20 to 30 patients, COVID positive patients, from home. But as a staff in general, the clinical managers have pretty much moved 50% on-site, off-site on a rotating schedule.
Now, you are the cardiac critical care clinical pharmacy manager. Wow, that's a tongue twister when I try to say that, which explains why I thought that, we should try to focus on the management of some of the cardiac complications in, these critically ill COVID-19 patients, amid the pandemic. And like you mentioned, these drug shortages. So what vasopressor are you all using as first line treatment for patients that become hypotensive kind of as well as hypoxic?
Yeah, I think it depends on the situation or the cause of their shock, right? So in those patients who are in septic shock, we're still following the normal algorithm that you normally would, right? So norepinephrine first, then adding on vasopressin to help decrease norepinephrine requirements. And then if requiring more pressor, then we would add on the other pressors as needed. But in hypotension due to sedation, for example, we're trying to use more phenylephrine in those cases, just to decrease the amount of norepinephrine that we're using, and reserving it for those patients in septic shock, due to the shortage or need for compounding and in the IV room.
On the Surviving Sepsis campaign, the COVID-19 guidelines suggest the use of norepinephrine as the first-line vasopressor, so that certainly makes sense to continue following that. I thought it was very interesting recently in the New England Journal of Medicine. They published some epidemiology data on critically ill patients from New York, and the thing that stood out to me was that out of the patients who required ventilation, almost 95% of them required vasoactive support on top of that. Is that kind of in line, at least in some sort of vasoactive support? Is that in line with what you've seen?
Yeah, I feel like I've definitely seen that in most of the critically ill patients, where initially when they're decompensating, they do require some sort of vasoactive support. And it depends on how long they actually require that support for. Sometimes it's for shorter, sometimes it's for longer periods of time. But I'd say typically in that initial period where they're crashing is when they're requiring the most support.
It's like they've really just lost all type of reserve at that point. It's kind of what it's sounding like.
Yeah, exactly.
Now, I think you hinted at this a little bit earlier, but have there been any, major changes to kind of your normal vasopressor compounding or utilization during this time?
Yeah, so not only for vasoactives, but for some of our other medications that we're using to support these patients. But we have, in order to help mitigate waste, we looked into drug stability of what we are considering our list of COVID meds that were provided by our critical care group. And it was determined that we could recommend extended length of administration of certain compounded drugs, such as the vasopressors, some of the sedatives, up to 96 hours if they were left at room temperature, and for most of them, up to 10 days if they're in the fridge. So those have been some of the things that we've used to help mitigate waste in the situation, as well as using higher concentrations. So the thought being, if we're compounding the bags with higher concentrations and we're extending the length of time that the bags are good for, then that would in turn decrease the amount of workload on the pharmacy.
Oh, it's nice when creativity can kind of shine in some of these settings. Now, what about the use of the smart pumps? Are they staying in the room? Are they going outside the room? I've heard both sides, and I can understand both sides of the argument, actually.
Yeah, so it's not being used in every patient, but there were statements released from the hospital and the pharmacy as to the use of using smart pumps outside of the patient's rooms. But in general, I feel like there are certain problems that you have to think about when you are using smart pumps outside of the room, such as making sure that you're cleaning the pumps appropriately when moved from inside to outside of the room, allowing pumps to be positioned outside of the room for certain medications might not be ideal, specifically since you're using a lot more tubing. You would want to ensure that the tubing is secured, unkinked, ideally off the floor. That way nobody's tripping or anything like that. Making sure that you're priming the tubing adequately, because then you could run into low flow infusion problems, dead space within the extension tubing. So those are all problems that you have to worry about, as well as the occlusion alert system not working properly, because as you use more and more tubing, that could delay the occlusion alarm potentially. So it's not being used for every patient, but just in certain situations.
And I think the other thing from a clinical or even a nursing side of things is, right, with some of these, like we'll use norepi as an example, right? When you go up on the norepi rate, right, you see that blood pressure change pretty quickly when it's by the bedside, whereas when it's outside the room, what happens? You probably have a higher chance of overshooting your target, because when you're staring at a map of, say, 50 over 30 or 40 over 20, what are you going to do? You're going to keep cranking that rate up until the blood pressure goes up. But with that longer tubing, it's just going to take longer for the drug to get to the patient.
Yeah, exactly. So you might see a delayed response, or you might get a super therapeutic response, depending on whether you actually prime all the tubing with drug first, or not priming it adequately. You might get that delayed response.
Now, have there been any preliminary talks or discussions kind of for what to do if some of the higher use vasoactive medications, potentially inevitably go on a shortage?
So using the higher concentrations and extended expiration dating, we thought that would be adequate enough to help reserve stock and mitigate waste. We haven't really run into too many issues with getting vasopressors in, but I'm sure at some point we'll have to become more creative in order to conserve. At this, I haven't really used as much midodrine as maybe we could potentially be using, but again, a lot of these patients aren't really requiring vasopressors for prolonged periods of time that I've seen, just in that initial phase of decompensation.
And it sounds like you all have gotten creative in a sense to almost help conserve the supply that you have, right? Of if we think it's hypotension just due to the pressure changes from intubation or due to sedation, using a low dose, short period a phenylephrine infusion versus taking that norepi infusion has probably help reserve some of those.
Yeah, I think it definitely has.
The two things that I think it will probably start coming, you hinted at a big one that I'm thinking is the midodrine use is probably gonna go up, and then I'm wondering if push dose vasopressors, if that is, even with the med safety concerns, if that might have to come to light if there's any shortage on anything. Who really knows?
Yeah, I don't really know. I mean, the push dose, especially for that staff that hasn't really had experience with push dose pressors. They might not be as comfortable with it because during this whole situation, there are nurses, there are physicians, other specialists that are now taking care of critically ill patients when on their day-to-day rounds or life that they're not dealing with those types of patients. So that might be another issue with trying to use these higher level critical care interventions.
Now, recently, we're having, and even today, I think I'm reading a new thing every day about the hypercoagulable state of many of these COVID-19 patients. And I think we're learning more and more that they are likely more prone to some of the VTE events and some of our other critically ill patients that are already at a high risk. So in this COVID-19 population, what's your general anticoagulation strategy?
So I think it's been changing every week now because, as you know, from all the literature that's coming out in this space, there's been both anecdotal and evidence from studies to say that a number of these COVID-19 patients are developing VTEs, some are having strokes, some are having acute coronary syndrome-like illnesses. And some of the studies have shown high rates of VTE from 25 to 40%. But those rates shouldn't be taken as conclusive because those studies had many limitations. Either they didn't provide what type of prophylaxis that the patients got. Some of the patients didn't get anything, or they either didn't comment on the strategy, or they received subtherapeutic dose of prophylaxis. So it's hard to say what the actual rate of VTE is in these patients, but based on some of the findings, things that would increase your suspicion or the patient's risk of developing a clot would be elevated D-dimer levels, which has been commonly found in these patients who have COVID-19. But those patients who you actually have a suspicion for VTE should be in case of typical DVT symptoms, like swelling in the legs or redness or pain. If you're trying to oxygenate these patients and they're hypoxemic disproportionate to what their respiratory findings are, or there's an acute unexplained right ventricular dysfunction on echo, these are the patients that you should be more suspicious of when you're assessing the anticoagulation strategy, whether it's prophylaxing with normal prophylaxis dosing, half dosing, or full therapeutic anticoagulation.
You mentioned that these studies where we're getting a lot of this have deep flaws, and you're getting zero arguments from me on that manner. So would you say that it's kind of business as usual in terms of DVT prophylaxis in these patients, or have you maybe considered, I've read some other places where centers are doing not full therapeutic anticoagulation, but maybe somewhere in between, like almost like a trauma dose, or even like the obese kind of low molecular weight heparin dose of 0.5 mg per kg Q12.
Yeah, so I'm glad you asked me that because before 2 weeks ago, we were just doing normal prophylaxis dosing of Lovenox and heparin in these patients, with preferentially choosing Lovenox, really from a nursing administration viewpoint to decrease the amount of times that the nurse actually has to go into the room and be in contact with the patients. But our hematology group has come up with a VTE prophylaxis guideline in COVID-19 ICU patients and the 9 ICU patients. But it is a guideline. It's not a policy. So prescribers can choose to not follow this guideline. But really what they're trying to do is recommend higher than normal VTE prophylaxis in these patients who you might have a higher suspicion for either developing a clot or having a clot. And that's typically patients who have a D-dimer of greater than 2 to 3 times the upper limit of normal, with maybe other findings of PE, such as not oxygenating well or further worsening of their oxygenation status, or if they develop other clots in other places. So for prophylaxis of VTE, what the guideline is recommending for patients with normal renal function is 0.5 mg per kg every 12 hours of Lovenox. If those patients have an AKI or on hemodialysis, you could use 30 milligrams of enoxaparin daily or high dose unfractionated heparin of 7,500 units every 8 hours. In these patients, we are doing anti-10A level monitoring, typically 4 hours after the third dose, with a non-therapeutic target of 0.4 to 0.6, just to make sure that they have adequate drug but are not technically therapeutic. Mm-hmm. And then for treatment, we are preferring Lovenox in patients. But if they do have AKI or HD or on CRRT, we're going with unfractionated heparin drips.
Now, in terms of monitoring, I want to ask a follow-up there. Have you found that the anti-10A levels, have they been affected at all by by this treatment course or by kind of the disease at all? Do the numbers seem real, I guess? Because I'm asking because for people who may be monitoring, APTTs, for example, in these kind of pictures, those lab values can be altered and kind of making it difficult to interpret.
Yeah, I'd say for the most part, the anti-10A levels do look appropriate or valid. But there have been situations where APTTs and anti-10A levels weren't necessarily correlating. So it's hard to interpret it. But for the most part, I feel like the anti-10A levels have been correct and valid.
Now, let me ask a follow-up to my initial question, kind of talking about the DVT prophylaxis and treatment and kind of what you're doing. Does your answer change at all for patients who may be receiving CRRT or even ECMO?
Yeah, so I think for CRRT specifically, I have seen issues with the circuit clotting as well as some of my other colleagues in other units. And it seems like it's clotting more often than just your normal run-of-the-mill critical ill patient on CRRT. Mm-hmm. Maybe that's just by chance, but that's what I've been hearing from other people from other institutions as well, is that the circuits are clotting much quicker than normal. So in some of those patients, we've been running heparin through the CRRT circuit. But if it does continue to clot, then we're moving to systemic heparin, or if they feel like they want to use a different agent because the heparin is inadequate. In some patients, we actually have tried our Gatraban drips. Whether it actually worked better or not, I can't really say. But then in ECMO patients, I don't specifically deal with ECMO patients in my current unit. But we already know these patients have a higher rate of both thrombosis and bleeding. And there's no data specifically in COVID-19 patients, what the specific agent or the targets for these patients on ECMO is. So currently, I think we should just be using our own institutional anticoagulation guidelines in these ECMO patients, because there's nothing to say that one agent over the other is better or what our targets should be.
And I've even talked about it on previous episodes that, you read about when these patients, decompensate, it's extremely quickly, like minutes. And I guess I'm wondering, when that happens, is PE in all of your differential, in addition to just the progression of COVID-19?
Yeah, I think you definitely have to consider PE within that differential, because as we've been hearing from some of these studies coming out of China and some other countries, or just from autopsy reports, is that a lot of these patients are developing microthrombi or large PEs when they are COVID positive. So it's definitely a part of the differential, especially if a patient has an elevated D-dimer, although D-dimer, as we know, can be nonspecific, not just for PE, but who are also having worsening respiratory function or not able to oxygenate them properly, where they just crash pretty quickly. I think it definitely has to be a part of the differential.
Isn't it funny that we've probably spent a decent amount of time when we're rounding in things preventing the ordering of things like CRP and D-dimers, and now we're building protocols based on some of these. And obviously that's what the evidence says, but it's just funny how that's changed so quickly.
It is. I think this has been, I mean, I've only been practicing for a few years, but it's been a crazy shift in how we're actually practicing medicine right now. A lot of it's just anecdotal medicine that we're practicing, and we don't really know exactly what the best option is or how we should be monitoring some of these patients. But we're just making up things out of thin air or very limited evidence.
Mm-hmm. Now, is there any push to add any additional anticoagulant options to the formulary, maybe in the face of a potential shortage? So like an example would be, I think almost all of us have Lovenox or enoxaparin as our low molecular weight heparin of choice, but maybe trying to add dalteparin in case of a shortage, maybe another strategy like, I don't know, DOACs or something like that. Has there been any type of discussions in that realm?
So I haven't heard of any discussions to potentially add other anticoagulants onto formularies, such as dalteparin or different lower molecular weight heparin. I know we were dealing with a heparin shortage a few months ago, but at this point, we haven't really heard of any issues with acquiring Lovenox specifically. I feel as though using DOACs in some situations may be appropriate, especially in situations where you don't expect patients to be going for procedures or they have adequate renal function. Maybe potentially using DOACs in certain situations might be appropriate. But in terms of use within the ICU, I would really stick with enoxaparin or heparin if there's renal impairment. And then reserving to DOACs when patients are on other units, like on the medical floors, or being discharged, and potentially continuing prophylaxis after discharge at home.
Yeah, I think that's a really good key point that you just identified there. Is like, you think of it, the DOAC says, oh, look, it's just one pill, you take it. But what if there's a procedure that has to happen soon? Then you have to allow how much time to wear off, right? Then you get into what, the worst case scenario of management of, bleeding from it. So it's just not as clean as we may think on the surface. So I think that's a really good point to kind of, especially while they're critically ill, really keep with the parenteral anticoagulants that have at least a shorter half-life, and we could manage any type of, complications from it. Now, the use of thrombolytics for ACS has become, I'd say, basically non-existent due to PCI and early intervention. However, with the shortage of PPE and the concern for medical staff, maybe possibly being infected, I've read and seen many centers are looking into using thrombolytics in a specific subset of patients rather than PCI. Is this something that your health system has at least looked into or had any type of guidance on?
Yeah, so this is something that has come up, and our interventional cardiologists at multiple campuses were working on a guideline for ACS in COVID positive patients. So it's pretty interesting that the thrombolytics have come up. It does make sense, at least to come up in conversation, right? Because we do want to limit the amount of PPE that we do, the amount of invasive procedures that we're doing, primarily to preserve PPE and minimize transmission of the virus to other healthcare workers and patients. But as we've seen in a lot of these studies that have been coming out, is that myocardial injury is seen in these COVID-19 patients, specifically the more severe ones, where they may show up with elevated troponin levels or EKG abnormalities, and higher troponin levels have been associated with more severe disease. I don't believe that that is necessarily due to thrombotic ACS, secondary to plaque rupture, for example. But I think in certain patients, it might be reasonable to use fibrinolytics, especially if they don't have the capability of doing PCI in a safe manner.
Yeah, the Circulation, the online publication had a really good article. I think it was released last week that talks about STEMI reperfusion in COVID-19, and they kind of have things to think about with risk assessment. And I think the big thing that stands out to me is, right, is this patient critically? Are they in cardiogenic shock from this MI? And if that's the case, thrombolytic may not be our best route, but for some of those, more selected patients, minimizing downstream risk of COVID-19, maybe thrombolytics might be appropriate. Now, generally speaking, go ahead.
Yeah, I totally agree. I think in most patients, it's reasonable to just continue optimal medical therapy and to defer invasive procedures if that's possible. And in some STEMI patients, to consider fibrinolytic therapy. And the fibrinolytic that we'd most likely be using in this situation would be tenecteplase.
Now, has there been any big type of education at all in regards to this, potential change or use of tenecteplase?
So not that I'm aware of, and as you can assume, just educating on anything during this time has been really difficult because we're not supposed to be gathering in groups. Everything is pretty much remote, whether it's conference calls on WebEx or Zoom. So I feel like educating via email is the only way to go in this situation. And potentially those people who are still on site could provide some education to those providers that are going to be dealing with this. But I mean, in these situations, there are going to be specialists that are involved in the decision making. We're not just going to be giving fibrinolytic therapy to, not just anyone is going to be able to administer fibrinolytic therapy.
Yeah, for all of us who have done education before, it's hard enough, let alone when you can't even get people in the room and bribe them with a little food or breakfast or something,
Exactly.
I think the thing that concerns me a little bit is, I think, I'm gonna take a step outside of New York here for a second, and I think there are a lot of hospitals who have been running at low capacity, right? Everyone's avoiding the health system appropriately, right? They're doing social distancing, quarantining. But I think one of the next waves that might happen are people who have had these symptoms, right, for a week or two, and then they finally get worse. And I hope this doesn't happen, but my concern is that, there have been people who've been feeling unwell for a little bit. They think it's the cold, and it turns out it could be a big, MI. Hopefully that doesn't happen, but, I'm wondering if that's going to be the case in the coming weeks or so as more time comes on in this pandemic.
Definitely. It's pretty scary to think about.
So on the same lines, kind of with thrombolytics, hypoxic, hypotensive, the worst case scenarios of those, right, lead to a cardiac arrest. And that's obviously one of the most high-risk areas for kind of disease transmission because everyone's running in and doing everything they can to help save somebody. And with little regard for themselves, right? That's what a lot of, especially those nurses, they're just so caring and loving. But obviously with COVID-19, right, a lot of that maybe needed to change. So how has your code response changed in this pandemic?
Yeah, so the code response has definitely changed from what I hear being off site. They're trying to limit the amount of people that are in the room at the time of the code, of course. one, to limit PPE, and two, to limit the transmission of the virus to others, to themselves. From a pharmacy perspective, unfortunately, we don't have all of our pharmacy staff trained in code response. So during the day, during the week, one of the critical care managers will respond to the code, but their response is limited to outside of the room. So the code cart and the med tray is being kept outside of the patient's room, and the pharmacist will prepare the medication and transfer it to one of the nurses or one of the staff that's in the room at the time.
Yeah, that sounds smart. And I think that's probably being done at a lot more hospitals and health centers of that way to try to prevent those types of issues. So there were certainly been a few, I guess we'll call them controversies related to COVID-19 and cardiology. I think in the first week or two, there were all these headlines, and I led a lot of people to kind of do some research. So I'd be remiss to not ask your opinion about a couple of these things. So I think let's start with the use of ACE inhibitors or ARBs. So has your opinion on the use of ACEs or ARBs in the ICU changed in regards to COVID-19 patients as compared to maybe just general cardiac or, medical critically ill patients?
Yeah, so I don't think my opinion of the use of ACEs or ARBs have really changed in my practice. But a little bit of background for those who don't understand why this is even being brought up is that there has been an associated link between ACE inhibitors and ARBs and the angiotensin-converting enzyme 2 or ACE2 and SARS-CoV-2 or the COVID-19 virus. So ACE2, that enzyme has been shown to be a co-receptor for viral entry of the virus. So there's a concern that the use of ACE inhibitors and ARBs would potentially increase this ACE2 and increase patient susceptibility to viral host entry and propagation. There has been primarily animal models that have shown some evidence in humans showing increased expression of ACE2 in the heart and some of the other organs and the urine. But based on what's currently available, in the view of using these drugs, which are primarily used in patients with cardiovascular disease, ACE inhibitors and ARBs really should be maintained or initiated in patients with those comorbidities that have a mortality benefit from those drugs, such as heart failure, hypertension, ACS. So according to the societies, really we should be continuing and maintaining these drugs as long as there aren't any issues with renal function or any contraindication to using the drugs in the acute setting, in which in the ICU we do have to hold them at certain points in time. But withdrawing RAS inhibition just preemptively in the situation for potential interaction with the virus, at this point, I don't think it should be recommended to discontinue these agents for that reason.
Yeah, that's a really good point that, there was some speculation, I guess I would call it that, some speculated that it could increase harm. Others speculated that maybe it could help. But I think the biggest thing is that there's no experimental or clinical data demonstrating either beneficial or adverse effects. So we should really be doing this as business as usual, right? If they're critically ill and you need to hold certain meds like you normally would, that's great. But if not, you have a heart failure with reduced EF, we shouldn't avoid using our class 1A recommended agents, when we can. Now, what about NSAIDs? Has your use of these agents changed at all due to COVID-19?
So I practice in a cardiac unit, so we typically avoid NSAIDs just in general, other than aspirin, of course.
Mm-hmm.
But the same type of mechanism of affecting the ACE2 is thought to be is why the conversation about avoiding NSAIDs in these patients has come up, along with in the past there have been associations with harm in using NSAIDs in viral pneumonia, potentially making it worse. But current evidence isn't really strong enough to infer a causal link of harmful effects of ibuprofen or other NSAIDs in COVID-19 patients. So I feel like if acetaminophen alone can achieve its antipyretic effect, the current evidence doesn't really advise against co-administration of ibuprofen here or there. So if you can use acetaminophen, I'd just go with that. There are multiple reasons why you wouldn't want to use other NSAIDs other than aspirin in a critically ill patient, especially since many of these patients have renal dysfunction, along with some other comorbidities that you would want to avoid them in. So I say for now, just avoid them if you can. But if you need to use it, go ahead.
So we're kind of rounding out our general cardiology medication overview. Have you found yourself using statins more than you may have otherwise?
So I think that's an interesting question because I did see a paper come out recently discussing the potential benefit of using statins in these patients. So as we know, statins do have some anti-inflammatory effects by decreasing some of those inflammatory markers. But it could also potentially increase IL-8 levels. So yes, it does have immunomodulatory effects. Is there any evidence to potentially say that this would be beneficial in COVID-19? Not to my knowledge. But if you need to continue a statin for a specific indication, such as those patients with ASCVD, diabetes, hyperlipidemia, you should definitely continue using them. Would I start a patient on a statin who hasn't been on one before just because they have COVID-19? I'd say definitely not.
You know, at a certain point, I feel like I like to practice a less is more approach in many of these things. And, you know, I think the theory of the use of statins kind of comes from there's some phenotypic data on specific patients with ARDS and having some benefits. So I think, you know, people may be thinking, you know, linking the COVID-19 and ARDS, but I'm right in line with what you're saying there is like, I doubt I'm going to be getting a patient like a new start on a statin just because they had COVID-19. Yeah,
exactly. I just don't see the utility in doing that. We're already throwing the kitchen sink at these patients anyway. So I agree. Trying to limit the amount of medications that we give these patients is definitely the way to go.
Now, you mentioned that you're not physically rounding right now. So how have you overcome some of the challenges that come from virtual rounding and not being physically present with the ICU team?
Yeah, I mean, as you know, and as many of your listeners know, as critical care pharmacists, we're used to being at the bedside and in ICU all the time, especially during rounds. It's been really frustrating, pretty challenging at times to manage these patients, especially since they're being sedated, they're on antimicrobial therapy, they're on anticoagulation. So all of those things are hard to manage remotely, as you can assume. And it's not as fun either. But I've been managing pretty well, I think, for the most part. Unfortunately, there are multiple attendings that are rounding on my now 25 to 30 patients. So it's not really feasible for me to like virtually zoom in to rounds because I couldn't round with everyone. But things that I've done to kind of help me out and make sure that all my interventions are being made is keep in contact constantly and consistently with the residents, with the nurses if I need to, with our pharmacy staff who are verifying orders, who are on site, and just being glued to my email because things are changing all the time, especially with drug shortages. and our guidance documents. So those are some of the things that have helped me along the way, and just knowing that there's a light at the end of the tunnel where I'm going to get back in the unit, and can't wait for that day.
So has it reached the point where you're sending like snarky memes or gifts to people like that, like the residents? Has it got to that point? Have you been gone that long yet?
I haven't sent anything. I may have thought some things in my head at certain points in time, or just said it out loud in my apartment with nobody here. But yeah, there have been some "what the heck are you doing" kind of moments. But yeah, I've tried to keep it PG.
Now, I think you've had some experience, or probably, like you've mentioned, some growing pains or lessons that you've learned just from beginning to now in terms of treating, COVID-19 coronavirus patients. If you had any, key tips or lessons or things to kind of help all of us, what would be things you'd want to reemphasize or pass along?
Yeah, I think that there are certain things that you want to think about when managing these patients. A lot of them look very similar. They're presenting in acute respiratory distress syndrome or ARDS. They're requiring high amounts of sedation to help support their oxygenation. A lot of them requiring paralytics. So just making sure that you're managing that adequately and being patient. So these aren't typical ARDS patients or your typical ICU patients where they may be on the ventilator for a few days and then can get extubated and go to the floors. Some of these patients are requiring mechanical ventilation and sedation for 1 week, 2 weeks, maybe even 3 weeks. So you have to be patient. And with being in the ICU for that long of a period of time, you want to make sure that you're paying attention to other potential infectious sources. So lines, some of these patients are developing bacteremias, which is obviously not a good thing. Ventilator-associated pneumonia, since they're requiring mechanical ventilation for such a long period of time. So those are some things that you need to look out for, as well as trying to manage their VTE prophylaxis and anticoagulation. Those have been the main challenges that I feel like we've had to deal with in these patients, as well as not necessarily having conclusive evidence for COVID-19 directed treatment for the virus itself. So I think just being patient, getting a Twitter account, because I feel like that definitely helps keep up to date with all the new literature that's coming out. I feel like if I didn't have a Twitter account, I'd be pretty lost in this whole thing, because I'm having to read every single day, learn as time goes on, and being flexible.
Yeah, if you would have told me in January that I'd be an expert on the use of hydroxychloroquine, I probably would have called you crazy, right?
Yeah, definitely.
Well, I echo all of those tips. I think those are awesome principles and things to keep in mind. Now, you mentioned Twitter. I think that's an absolutely important point. And you definitely don't have to be active. You can kind of lurk and just follow good things. So hopefully we can get you some followers. Peter, what's your Twitter handle? We'll get some of the listeners to follow you.
My Twitter handle is at PNFarmD. So yeah, definitely give me a follow.
You hear that, listeners? Everyone give them a follow. And of course, if you're not, please follow the pod Twitter account at Pharmacy to Dose. That's TO to Dose. Now, Drayton led off our discussion today and gave us his Chicago deep dish recommendation. Now, when in Chicago, eat as the Chicagoans do. But hand up, at heart, I'm definitely a New York style thin crust pizza man. So what's your favorite pizza spot in New York?
So it's funny that you asked me that, because I'm actually a pretty new New Yorker. I moved up here in July. So I haven't really gone to any of the famous or more well-known spots, but any of your local pizza shops here in New York have great pizza for the most part. I'm from Philly, so I'm a cheesesteak guy. So if you need my cheesesteak recommendations, it's not Geno's or Pat's.
Oh yeah, come on. We had Todd. Our last episode had Todd Miano, who was from Philly, and he gave some. But I'm always open to new recommendations. So lay it on us.
Yeah, I'm more of a Jim's Steaks kind of guy. So if you ever go to Philly, great city, try out some Jim's.
The listeners now have 3 cheesesteaks to eat, but in Philly, like that's not out of the realm of ordinary of coming home with like a cheesesteak eating contest or tasting kind of thing. I don't think so.
Yeah, definitely not.
Okay, now we got to go back to the pizza question, because I like to ask this question too. What are your preferred pizza toppings? Like when you order, are you a less is more in that arena, or are you definitely kind of a more is better approach?
I think it depends on my mood. I'm a big mushrooms and broccoli fan.
Whoa!
So I like to get some veg on there.
That was an unexpected answer. Broccoli. All right, we're gonna have to try to give that a follow. Look at that. You're giving us some healthy recommendations in the quarantine.
Eat your veggies, kids.
Now we're stuck inside more than ever. So what's a good quarantine kind of entertainment recommendation for the listeners? Because it sounds like you've been, potentially streaming some shows being in your apartment for this long.
Yeah. So before quarantine or DQ, however you want to say it, I was not a big TV guy. I always need to be doing something. But my girlfriend got me into Netflix, and my best recommendation that I can give you is Money Heist, or like they say in Spain, La Casa de Papel. It is an awesome series. There's four series or seasons on there. That you should definitely check that out. It'll definitely be worth your time.
I think that's great. I haven't listened to that, so I haven't watched that, so we'll have to add that to the list. You claim you didn't watch Netflix. Is that for real? You didn't watch Netflix before all this? That's maybe the most impressive thing or surprising thing from all of this.
Here or there, but I'm not a big TV guy.
Well, Peter, I really appreciate you coming on and giving some insight into kind of the management of some of these patients, and definitely want to give a heartfelt thank you for everything. Even though you're not necessarily in the hospital, but you are definitely doing things that are helping save lives, and all of us are thinking of you and your colleagues in New York, both in the city and some of the surrounding areas. So we really appreciate and sincerely hope that you and your loved ones stay safe with all this happening.
Yeah, thank you so much, Nick. It's been a pleasure talking to you on the pod, and it's an honor having me on. So I really appreciate the offer, and I wish everybody stay safe out there, keep social distancing. It'll be worth it in the end, hopefully.
Absolutely. And you share an office with a current friend of the pod and former guest, Corinne. So you'll have to tell her hi from the Pharmacy to Dose crew of one, which is me. Okay.
I definitely will. All
right. Thanks for coming on, Peter.
Thank you.
I can't thank Peter and Drayton both enough for coming on with everything that they have going on, managing things both professionally and personally in these highly affected cities. They took the time to talk about their experiences, their knowledge, and what they've learned in these COVID-19 patients, passing it on to all of us. So a massive thank you. And to everybody who's come on the podcast recently. I know balancing everything is hard and challenging, and I really appreciate making time for all of us. And of course, have to give a massive thank you to you, the biggest friends of the pod, the listeners, because obviously this podcast doesn't exist without you. So if you have ideas, whether it's COVID or non-COVID related, please let me know. If you have any feedback, positive or negative, please do the same. Twitter or Instagram at pharmacy to dose, TO to dose, or via email at pharmacytodose@gmail.com. And I said it last time, the Instagram's been lacking just a little bit, but hey, we put a couple posts up. So come check it out. There's going to be more coming here. And on our website, you'll find some of the show notes for the things that that Peter, Drayton, and I kind of covered in this longer episode. And I would love to hear from each and every one of you. And so just kind of an update, when there's COVID-19 related episodes, normally I like to release, bi-weekly on Wednesdays, every other week. But with our knowledge and the literature just changing so rapidly, if I have any COVID-19 related podcasts, I'm going to try to release them as soon as I can. And that's why we're kind of releasing these in succession, because in 2 weeks, some of this information might have changed, right? Our knowledge is ever growing. So that's kind of why I'm releasing them on a non-normal schedule. So just really wanted to let all of you know. And until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.